Thank you, Pradeep and the organizers of the conference. And it's my pleasure to talk on optic disc evaluation. And Dr. Chandrasekhar is here with us. He is the one who has really taught all of us how to evaluate the optic disc. And I would also like to point out that Pradeep has shown us what OCT can do and what OCT cannot do. And the most important thing is that if you do any imaging test or you do perimetry also, I would insist that you should first see the optic disc clinically before you start interpreting all these other tests. If you don't follow a systematic protocol of clinical evaluation first, followed by the imaging tests, you are likely to be misled in a lot of situations. To clinically evaluate the optic disc for glaucoma systematically, we have this 5-rule principle. The rule number 1, first thing you see is the size of the disc by looking at the scleral ring. That's the first R, to see where are the limits on the size of the optic disc. How do you see? Usually in normal individuals, you can easily identify where the disc ends and where the retina starts. And you need to evaluate the white ring which delineates the optic disc. That will tell you the size of the optic disc. In the first lecture, Dr. Sood showed us how you can be misled in small discs to erroneously diagnose it as normal when actually it is glaucomatous. And you can overdiagnose in large discs. So before you start looking at anything, I would say even if before you start looking at intraocular pressure, you should look at the optic disc and be very sure whether it is a small disc, an average disc, or a large disc. The way to do this, you can use the white spot of the 5-degree illumination of the Welch-Allen ophthalmoscope and put it over the disc. If it covers the disc more or less, it is an average size disc. If the disc is smaller, that means it is small disc. If it is larger than the size of the white spot, that means it is a large disc. More accurately, you can do this using the slit lamp and using the vertical beam because you have a measuring graticule with it. If you use a 60 diopter lens, you will get the actual measurement. But if you use a 78 diopter lens, the magnification factor is about 1.1. But with the 90D, the magnification factor is a little more. So you have to apply the appropriate magnification factor and you will get the exact measurement of the disc by vertical and horizontal. An average disc, the vertical diameter is 1.8 millimeters and a horizontal diameter is 1.7. This is the way you can do it with a slit lamp. You put the slit beam right next to the disc and gradually reduce the height of the slit beam that it overlaps and you can measure from the graticule. If you get 1.4 on the graticule, that is a small disc. If you get 1.9, that is an average disc. If you get it larger than 2, then that is a large disc. So as Dr. Devan showed us, small discs may have small cups, and if you just see the cup, you are going to be misled. The small area of thinning on this upper pole is going to be missed, and you will diagnose this as a normal disc and not a glaucomatous disc. There are some discs which have very large peripapillary atrophy areas, and here marking out the optic disc will be a little challenging. After you have seen the size of the disc, the second rule is to see the neuroretinal rim. The neuroretinal rim is the portion of the peripheral of the disc where the neural tissue is all concentrated. So you have to measure the distance between the edge of the disc or the scleral rim and the point where the blood vessels are hooking over the edge of the neural rim, and you have to measure it in all the 4 segments, the inferior, superior, temporal and nasal. And we all know that numerous studies have shown that in a normal disc, the thinnest rim is temporal, followed by the nasal, the superior, and the thickest is the inferior. So you have to look at where the thinnest part of the neural rim is, and in a normal disc it should be temporal. If any of the other 3 is thinner than the temporal, then that is marked as abnormal. And this is commonly known as the isn't rule, and Dr. Sood alluded to that right in the beginning of this session. So you have to identify local areas of rim thinning and notching. As you can see over here, this is the temporal rim, and you can see here the superior rim here is thinner than temporal, and that's what we are looking for. That is a localized notching. You can see here the other here the temporal rim is much thicker than the inferior. This is abnormal. So you are going to mark this as abnormal, and that's a notch. You also have to comment on the color of the rim, and pallor of the rim, which if you see increases the likelihood of non-glaucomatous or neurological causes of optic atrophy rather than glaucoma. So if you see a good neural rim but which is extremely pale, you are going to suspect more of neurological causes. The third thing you have to see is the nerve fiber layer, which is of extreme importance, and Pradeep Vyas was showing us on the OCT, but I would insist and encourage you to look at it clinically even before you see it on the OCT. And the nerve fiber layer is seen very well sometimes with the red free light, and you have to see the striations, the brightness, and the visibility of the retinal vessels. If the vessels are seen better, that means that the nerve fiber has got eroded, and you can look for what we call diffuse defects and localized defects. So this is the normal distribution of the nerve fiber in the retina, and usually it is concentrated on the upper and lower poles, and that also the lower pole has got more striations. This is the normal. You have to familiarize yourself with what is normal and then start looking at abnormal. And this is an example. Usually there are bright striations here in normal eyes, but when you see blood vessels appearing more prominent because these striations around have reduced, that is a sign of diffuse nerve fiber layer loss. And more concentrated nerve fiber layer loss, you can see the striations here, hardly any striations here. As in advanced glaucoma, you lose most of the striations. The fourth thing you are going to look at is the peripapillary region for atrophy. Peripapillary atrophy occurs in two kinds. You have the alpha zone, which is more peripheral and which is not a complete atrophy. There is hypopigmentation usually, and it can be seen even in normal eyes. The beta zone is more specific for glaucoma, in that you are going to get atrophy of the retinal vessels, the retinal epithelium, and more visibility of choriocapillaries and large choroidal vessels. Many times the area of the beta zone corresponds with thinning of the neural rim, and even in progressive glaucoma it is known to increase in size. So keeping a drawing in handy where you have drawn the beta zone would be useful. The last thing you have to see is for optic disc hemorrhages, which keep appearing and disappearing. Looking for hemorrhages can be very tricky, so if you have a patient who is constantly moving, it might be better to take a photograph and look at it, because small hemorrhages like that sometimes aren't easily visible. Most important is that if you don't keep looking at them, they're going to disappear in 2 to 6 months. So you should look, even if you don't do a very detailed disc evaluation for a patient who has come just for an IOP check, just having a look at a disc and trying to see if any hemorrhages appear is very, very useful. It will identify progressing patients for you. So detection of hemorrhages requires very careful examination. Sometimes it is very subtle, as you can see over here, and sometimes if it is adjacent to a blood vessel, it is commonly overlooked. I think there is very little time to discuss all the examples, but this is more, if you want to take a course on this, just disc evaluation, we can take a detailed course on that, discuss how small discs and large discs, you have to not get carried away and look carefully at the neural rim and try to see if there are any localized nerve fiber layer defects and hemorrhages, as you can see in this patient, and identify them. After you have seen the disc very carefully, you need to quantify whether the disc is falling into what kind of damage. Is it a normal damage? Is it an advanced damage? And you need to follow this. And for this, Dr. Spaeth has given us this scale, which is the disc damage likelihood scale. And that classifies, first, you have to look at the size of the disc. You have to classify it as less than 1.5, 2 millimeters or more than 2 millimeters. And then you have to look at the neural rim. So if you have a disc which is less than 1.5 millimeters and you have to look at the thinnest portion of the neural rim, if the thinnest portion of the neural rim in a small disc is 0.5, then you are going to grade it. These are the grades. They are graded from 0 to 7, and in 0 you have A and B, and 7 also you have A and B. And if you look at it carefully, the larger the disc is getting, the smaller he is allowing the thinnest portion to be. So in a large disc of more than 2 millimeters, the thinnest portion can be as thin as 0.3 and still be classified as 0A, which is normal. But as you go down, the area of thinning becomes lesser and lesser, and then you come to this grade 3 where you are having 0. 0 means it's a complete thinning, there is no rim, it is completely notched out right till the edge of the scleral rim. So if you have less than 1, that means that, or it is 0 in 45, less than 45 degrees, then it is graded as 3, and it keeps on increasing, and finally you go in more than 270, when of course it will be the most advanced grade. Because time is short and I have already finished, you can refer to this, easily available on the net, and follow it clinically to grade your discs and see if they are progressing from the lower grades to the higher grades with time. Thank you very much.